Another good morning. This is Dr. John Bennett, broadcasting from Miami. We have the pleasure here today of having Joni Aldrich, a cancer support podcaster and advocate, along with Mark Pritchard from England, as well as a couple of panelists, and we're going to discuss cancer support. Welcome. Well, first we'll introduce the panel. Hello, Simon.
Hello, everyone. Thank you for inviting me here. I'm looking forward to the presentation.
Thank you, Simon, and welcome. And Slaven.
Hello everyone, I'm Slaven, I'm here in Croatia and I'm looking forward to the presentation and enjoying the conference.
Thank you, Slaven, and I'm Dr. John Bennett once again from Miami. And welcome, Joni, it's all yours.
Well, thank you. Well, first let me start with a little bit about my background. My husband Gordon was diagnosed with multiple myeloma, a rare form of cancer, in 2004, and from that experience we learned a lot, and eventually Gordon did pass away from his cancer, not from multiple myeloma, but from metastatic brain cancer. And that's when I learned that going through a brain illness is a really unique experience with someone that you love. And tomorrow, actually, from 5 to 6, I'm going to be talking with my friend Julie Houston, and we're going to be talking about caregiving for a brain illness patient. So, I went through that experience, and then 3 years later, my mother had metastatic lung cancer, and hers metastasized to her brain. And again, different situation. And a year after we lost her, my boyfriend had a brain tumor, a benign brain tumor. So obviously, I've been involved in this a great deal, and that's one reason I was so interested in the conference. And thank you so much, John, for letting me come and talk about the patient viewpoint, and again tomorrow the caregiver viewpoint, because now what I've learned through 8 years of cancer caregiving and patient safety advocacy is that we're not in this alone. We're all together, the family, the caregiver, the medical practitioners, the patient. We're all in it together. We call it now in the United States our medical home, and it truly has to be that. So I'm very excited about this topic today, and without further ado, John, you want to bring up the PowerPoint?
Sure. Okay. And just direct me, Joni.
Okay, I will. Oh, for some reason, some of the slides went dark. But anyway, I was looking around preparing for this, and I found a book by Dr. Frank Vertusik Jr., When Air Hits Your Brain, Tales from Neurosurgery, and I thought it was so cool I wanted to include it because, of course, we're going to be talking to Mark Pritchard today, who went through a brain aneurysm. Neurosurgery, and this is what it says in there, neurosurgery is an arrogant occupation. Astronomers study the stars but never touch them. These scientists must be content with the shadow nature cast upon their instruments and photographic emulsions, but not the neurosurgeon, for whom the greatest mystery of creation resides in a few pounds of greasy flesh and blood. Only the neurosurgeon dares to improve upon 5 billion years of evolution in a few hours, the human brain. I absolutely love that, and I think it puts in perspective all of your guests today, John. So go to the next slide.
Okay, I hope this comes up, Joni. It doesn't look like it's here in this.
Yeah, it looks kind of dark. We may have to go to, I may have to, I don't know why that turned dark, but I can pull up my presentation.
Yeah, please. Can you do that?
Okay. Yeah, I will, if you'll take it off.
Yeah, in the meanwhile, Mark, can you introduce yourself while Joni's doing that?
That's a great idea.
Yeah, sure. My name's Mark Pritchard, and I'm here to share my story of neurosurgery. In fact, my wife and I have quite a big story because 7 years ago I suffered a brain hemorrhage. I had endovascular coiling to fix that. I started writing a book about it a few years later, and then 6 months into writing the book, my wife Sarah developed breast cancer. And of course, everybody looks at us with concerned eyes, but we're okay. We've turned everything around. Sarah's since beaten breast cancer, and I've overcome my condition to all intents and purposes. But we have some wonderful experiences to look back on that have changed.
Well, while we continue on, Mark, why don't you continue to describe your journey while we're waiting for Joni?
Right. Well, yeah, I can do that. I can start from the beginning, and if you need to switch over, just tell me to
Sure.
stop.
Okay, great. Okay, thanks.
Yeah, it started in Easter 2009, so a similar time of the year to now. It was a few days before Easter. It was a Tuesday before Easter. I had a subarachnoid brain hemorrhage. It was only a small hemorrhage, by all accounts. So the amount of blood that came out wasn't a terrific amount. They told me that they were going to take me to a hospital about 12 miles away where they got a good neurosurgery department. But while they were waiting for me to go, they were waiting for a bed, waiting for the ambulance. It became clear that the blood that had came out clotted and blocked the channel where the fluid drained, this cerebrospinal fluid.
Right.
Correct me if I use any incorrect terms, because I'm not medically educated, but it blocked where the fluid drains into the spine, causing hydrocephalus, which then sent me into a coma.
Okay.
So then they rushed me immediately to the neighbouring hospital to rectify that. Drilled a hole in my head. You might just be able to see it there.
Okay, Mark, why don't we continue this? We got Joni's slideshare going finally. We'll continue this story, okay?
Yeah.
Okay, Joni, it's all yours there.
Oh, thank you. Well, I wanted to share some facts about aneurysms, brain aneurysms, because I really didn't know, and I realized that a lot of people sharing the conference today are neurosurgeons, so I'm sure they're familiar with this. But for me, a novice, I wanted to share some facts and figures. An estimated 6 million people in the United States alone have an unruptured brain aneurysm, or about 1 in 50 people. That really surprised me. I had no idea, but usually they don't have any trouble with it, like Mark did. The annual rate of rupture is approximately 8 to 10 per 100,000, or about 30,000 people in the United States suffer a brain aneurysm rupture. There is a brain aneurysm rupturing every 18 minutes. Ruptured brain aneurysms are fatal at about 40% of cases. Mark, I think you gave me a third, but evidently it's a little more than that. Of those who survive, about 66% have some permanent neurological deficits. So we are absolutely blessed to have Mark here with us today, obviously. Approximately 15% of patients with aneurysmal I can't say it, hemorrhage, SAH, die before reaching the hospital. Most of the deaths from the hemorrhage are due to rapid and massive brain injury from the initial bleeding, which is not correctable by medical and surgical interventions. 4 out of 7 people who recover from a ruptured brain aneurysm will have disabilities, and brain aneurysms are most prevalent in people ages 35 to 60, but they can occur in children. Let's go to the next slide. Let's see. Let me move. Okay. There you go. Now.
Okay, well, I think we're off the screen share, Joni.
Okay, I'm going.
Okay.
Give me a minute. Okay.
Okay, well, we're all learning this, Tech.
Yes, that's right. Okay. Most aneurysms are small, about 1/8 inch to nearly 1 inch, and an estimated 50 to 80% of them do not rupture during the course of a person's lifetime. Women suffer from brain aneurysms more than men, 3 to 2. So again, Mark, you're rare. And ruptured brain aneurysms account for 3 to 5% of all new strokes. Accurate early diagnosis is critical, as the initial hemorrhage may be fatal. So it may result in devastating neurological outcomes or may produce minor symptoms. Despite widespread neuroimaging availability, misdiagnosis or delays in diagnosis occur in up to 25% of patients. There are almost 500,000 deaths worldwide each year caused by brain aneurysms, and half the victims are younger than 50. So these are some pretty amazing numbers. Let's see. Okay, can we still see?
No, we're off the screen share again.
All right, let me, again, yeah, we'll get used to this.
It's okay, it's all right.
Have to get used to it by tomorrow.
Yeah.
Okay, and finally, Mark, this is you. And Mark is going to talk to us about his anniversary, which is actually coming up. His book is I'm Never Ill, A Journey Through Brain Surgery and Beyond. So without further ado, let's go ahead and bring Mark back in. So let me go out of
Okay.
screen share. Did
Okay.
that work? Yeah.
Yes. Yes. Okay, Mark.
Mark, tell us about what symptoms you had prior to this. That was the most amazing to me. Were you feeling anything? Did you know that something was wrong?
Bizarrely, no. It happened all of a sudden. It's all a little bit vague, to be honest. I was just pottering around in the lounge. It was just before going to bed. It was probably around about midnight on the Tuesday just before Easter. But no, there's no warning at all. But I was struck by this pain. Described as a pain, it was more a pressure, an intense pressure inside my head over the top, that kind of area. At first, I've never suffered a migraine before, so I thought, I wonder if this is a migraine. Perhaps that's all it is. But because it was a small brain hemorrhage, I was still able to function. I was wandering around holding my head. I was thinking, oh my God, what's this? And after a while, I thought, well, I'm going to have to call for an ambulance. So I did that, and I was living in a first floor flat, and I was even able to walk down the steps to meet the ambulance. I had to, because I lived in this kind of cul-de-sac where anybody tried to find my place, they couldn't find it, so I always had to try and find them. So I was fortunate I was able to walk down and say, look, here I am, this is what happened. And anyway, they then took me to the hospital and kept me there overnight, and in the morning they did the CT scan, and they told me I had a small brain hemorrhage. And of course I explained this earlier at this point, and then they were waiting to take me to the hospital in Cardiff. It's called the Heath Hospital, and it was during that time then, while we were waiting, I slipped into a coma. It was quite clever, really, because my wife had just come in. Well, she wasn't my wife at the time. We'd only known each other for 6 months, and she came in to see me before I slipped into the coma, and she told me that the divorce had just come through. And it was a few hours later, or within the next few hours, I slipped into the coma, which was quite a neat trick.
Oh my goodness.
But when I woke up a few days earlier, she was still there, and and that's very much the beginning of our story.
Wow. And you were living by yourself. Now,
Yeah.
obviously when a neurosurgeon tells you this, or when you get this news, it's fairly devastating. It's got to be very frightening for you.
At the time when they told me, I think it may have been the way they told me, or the fact that I may have already been beginning to slip away. I wasn't alarmed when they told me that morning in the hospital, around about 11 o'clock probably. So yeah, they just said, no, everything's fine. It's just a small brain hemorrhage. Everything's gonna be all right. We'll take you to the Heath Hospital soon. But of course, then everything gradually began to slip away, and I was oblivious to the fact that it was slipping away. I don't ever remember thinking things aren't right here, although other people were aware of the fact that I was beginning to slur and get all my words mixed up, a bit like normal, really. And then the next thing I remember was coming round from the coma, which was on Good Friday. And my favourite joke, I might as well say it. I say so many times that I'd love to say that I arose on Easter Sunday, but I woke up on Good Friday.
Close enough.
Pardon?
But close enough. It probably
Well,
felt
close enough,
good.
yeah. In fact, when they took all the stuff out of my mouth, the kind of the ventilator, and they started to talk to, or allowed me to talk for the first time, I can remember the doctor saying, do you know where you are? And my answer was neurology. I knew everything that had happened. I remembered everything that had happened. I wasn't in neurology as it happened. I was in intensive care, but it was a pretty good guess.
Wow. So when did they decide on the surgery?
Ah, right. Now, the aneurysm I had is what they referred to as a blister-like aneurysm. It's a very small aneurysm. Now, obviously, again, this is my unmedically educated knowledge speaking. In order to fix an aneurysm, you either push a coil up inside, or clip it from the outside. And it was too small to put the coil up inside, and there was not enough of it to clip it from the outside. So what they wanted to do, I mean, they took a few weeks before they decided how they were going to go about it. They wanted to put a balloon through the catheter in the groin, femoral artery, and all the way up. And they wanted to put a balloon in the carotid artery to block off the blood supply to the damaged blood vessel. And in order to do this, they needed me to be awake. And again, I'm sure all you experts will understand all this. Apparently, when you block off the blood supply in a certain place, different people's vascular systems in their heads, I think, are plumbed differently, slightly, so that they don't know whether the blood's going to flow to all the bits that it needs to flow to. Mm. So when they put the balloon in, they then needed to do what they referred to as a blood flow test. They would ask me to for 30 minutes, every 5 minutes or so, they would ask me if I could move my arms, legs, could I talk, and so on. And I remember them afterwards. I can remember the doctor saying, "Oh, right, it's 27 minutes out. That's good enough. Let's put just a little bit more. I don't know if it's air or some other gas, whatever you put into the balloon. Let's just put a little bit more in." And as he did that, I had this excruciating pain and complete double vision on the operating table. Now, it seems that it had touched one of the cranial nerves. I always get confused between the fifth and the sixth cranial nerve, but it's the one that operates the lateral rectus muscle on the left hand eye. And that had obviously been touched, and so the doctor then decided, well, we'll have to abandon this, and he kind of dismantled everything, pulled everything back out. And this was on a Wednesday. And they decided then on the Friday, 2 days later, that they were going to put 9 or 10 platinum coils into the carotid artery. Whether they were all in that particular artery or various locations off, I really don't know. This is where you guys understand more about it than I do. They said 9 or 10. I never got to the bottom of whether it was 9 or 10, but I had the option. Am I okay to continue? If you've got any questions you need to ask, because I'm kind of talking non-stop here.
No.
Okay. I had the option of having a general anesthetic for this, because they obviously the blood flow test had worked, and that's the only reason they wanted me to stay awake. But I opted not to have the general anesthetic because I didn't want to be in a situation where I woke up with this complete double vision and severe pain. I wanted to be able to tell them there and then. So I took a deep breath and said, well, okay, I'll stay awake. So they put the coils in. The first one went in just there. I remember I could feel them as they went in. This is where a lot of people are fascinated when I tell them about this, because it's close to the ear. I could hear it going up, and it was squelching and squeaking as it went up. And the first one was there, and I get some pains with that every now and again. I call it platinum number 1. When we got to about platinum coil 4 or 5, I started to get the pain again that I'd experienced on the first occasion and the double vision, but not to the same extent. And I said to them, look, it's coming back. They said, it's okay. When we put the next one in, it'll go. And I mean, this was the first time I actually began to doubt the doctors, and I thought, oh no, this is all going to happen again. But true to what they said, they put the next one in, the pain went, and the double vision went, and then they carried on, put the rest in. The last one went in just there. So I know the first one was there, the last one was there. And now I'm in a position where the scrap value of my head is worth more than the actual value of my car and my wife's car put together.
Wow. Well, tell us about recovery, Mark. What was that like?
Right. Well, strangely enough, there wasn't a lot of brain damage. The only thing that was affected was my memory. Initially, I was very forgetful. I've always been forgetful anyway, more forgetful than most, as it happens. But I was very forgetful. I'd go and do the dishes, and then 15 minutes later I'd go back to do the dishes again and think, well, how did these get done? But over time, over not too much time, that seemed to heal itself. I had no loss of any faculties in terms of my limbs or anything. That was it. It took a couple of weeks before the pain. I had a lot of pain on platinum coil number 1. I had to take painkillers for about 2 weeks, and then after that, the pain went. Something very interesting. Oh, let me just go back. Sorry, going back to you say about recovery. I was back in work after 3 months, and I've just over 3 months. My daughter and I flew to New York. I'd promised her in the February beforehand. We booked this trip to New York, and I can remember when are we all still here?
Yes.
Yeah.
Okay. Yeah, I can remember. You know, she came to see me in hospital and said, you know, are we still going to New York, Dad? And I was like, well, there's a big question mark over this, and I really didn't think we would be able to go, but as it happens, I did, and that was 4 months after the operation. So I was very, very lucky.
You were incredibly lucky. Well, what would you tell other aneurysm patients, Mark, that may go through this in the future? You know, obviously from the information that I provided earlier, you know, we don't know. But are there things, let's talk about when it happened. What advice would you give people if they start seeing signs of something going on that they don't understand?
Well, again, it's difficult for me to advise on all instances because, I say, mine was a very small one. Say the pain was, say, it was an intense pressure in my head, and I mean, it's the same with, I mean, you know, my wife Sarah's had breast cancer, and there is a kind of a parallel here that if you think that there is something wrong, in Sarah's case, the lump, in my case, the pain in the head, do something about it straight away. Don't bury your head in the sand and think, oh, maybe it'll go away, or perhaps in, you know, my wife's instance, well, you know, perhaps it's benign, perhaps it's, or, you know, what if I have to go through chemotherapy, and all these different things can make people put things off. But my brain hemorrhage, I put it off. Again, my sense of passage of time over the course of, you know, when it actually happened is, I mean, it's, I don't really know, but I guess that it was about 15 minutes before I phoned for an ambulance, and for somebody that had a bigger bleed, that 15 minutes might be too much.
You know, Mark. One thing they teach us in medical school is you do a CT, and Simon, I think, will agree, and Slav, and if you have a patient coming into the emergency room and they say that this is the worst headache of my life, you get a CT right away. Was that the worst headache of your life?
Yeah, there's nothing like it.
Okay.
Nothing compares. I don't get headaches, as it happens. I'm one of these people that, you know, I don't get you. I have had headaches, but I don't suffer from headaches like, you know, a large percentage of people do. But no, it was a kind of pain that made me know that reaching for the medicine cabinet wouldn't do anything.
Right.
Yeah, I knew that. I knew there was something wrong that was different.
But yeah, that's the thing that teaches in medical school. And your CAT scan was done the next day. Is that because you were in a small hospital and they couldn't do a CAT scan?
I don't know. This is completely out of my hands. All I can say, it was over the Easter time. Maybe there was a limited number of staff. Right. Okay. I was taken in, say, the early hours of the morning.
Small hospital.
Yeah, it's all. Yeah, I mean, now I'm thinking about it. I mean, it hadn't really crossed my mind as it happens until you said. We probably had to wait for the day staff to turn in.
Right. No, there are hospitals here in the States. The same thing happens. If it's a small hospital, you wait till the next day, unless it's a true catastrophe.
Yeah.
So I'm not saying anything bad about English medical care.
No, I don't know how to compare either. So, but I have no complaints about the care that I've had or my wife.
Okay, very good.
So, Mark, why was it important for you to write your book?
Okay.
A lot of people think that I did it as a form of therapy to get some kind of closure, but that wasn't the case. I mean, I do write. I enjoy writing. I write for my employers, as it happens. I'm not allowed to talk about my work because my employers are the UK government, and this sounds really kind of very secretive. It's not, but I'm just not allowed to talk about that. But I do write for my employers. But what I initially intended to do was, you see, when I was in hospital, it became apparent to me that there were lots of people who were in very, very poor states, very poor medical states, not getting any visitors at all. And I wanted to write something that I could give to hospitals, patients, or whatever, just a little story about what had happened to me and how I'd recovered, just to give them a bit of hope. But it developed, you know, kind of one sentence led to another, led to a paragraph, led to a chapter, and all of a sudden I had 61,000 words, and it was a book. It took me a bit on and off, about 2.5 years to write it, because obviously Sarah had a cancer during that time, and I played a few games of Candy Crush, if I'm honest.
Wow. Well, what other advice do you have people that go through this, Mark?
People who go through it, well, what I would say is, I mean, we're very lucky. It's had a very positive impact on our lives. There are people who go through a lot worse, for whom the impact of the brain hemorrhage on their lives is completely different. It's difficult for me then to advise somebody that, that perhaps has lost use of the arms or legs, or, you know, down one side. I can't offer much advice for that. But as far as my own condition is concerned, what it's actually done is it's made me draw a kind of division. I had life take 1, and I'm now on life take 2. And what I do now is I live for now. And once you've seen, if you kind of looked down the barrel of the shotgun and pushed it aside, you can develop a sense of almost like invincibility. So I'm not explaining this very well now, but I have got 9 bits of metal in my head keeping me alive, you see, because I got attacked by a neurosurgeon once.
No, you're explaining it well. You know, it's good to get the patient side of it, you know, rather than strict clinical findings, etc. You know, how you felt and what made you go to the emergency room and stuff like that. You know, it's an area. Well, that's why I like this platform, Joni and Mark, and Simon will agree, I'm sure, is you kind of we're given a platform to go into areas which I think medicine really doesn't go into enough, which is the patient side. To hear, you know, it's not a textbook thing, and it's good to hear what the patient says. And I'm looking forward to hearing Joni talk tomorrow, and I believe she has another speaker talking about his experiences with brain problems. Because yeah, the brain it's a serious. I mean, let's face it, it's a serious organ, and you know, it's so multifaceted. It's not strict clinical findings. It involves emotion. I mean, there's no other part of the body. You know, if you strain a muscle, break a bone, it's a strict structure. But the brain, you're talking something very complicated, and you know, it's good to shed some light on the patient side of it.
Yeah, especially to me, it seems like, you know, the important part of this, of course, is the warning signs and being able to get medical help as soon as possible. But also, it was great for you, Mark, to share what it's like to have brain surgery, because many people might be really terrified of that. And the way that you explain it, I think it's very important, because you don't exhibit any of the signs that, I mean, it would terrify me, I think. So I think your story is very poignant and very important, and also that people get to see you and see that you can survive.
Yeah.
Well, you know, one question that Slaven is asking, because his connection is not very good over in Croatia, what would you argue is the most important step in the out-hospital care about brain cancer patients? I guess it's directed to both people, Mark and Joni.
Give me that question again, John.
Yeah, well, what would you argue is the most important step in the out-hospital care about brain cancer patients?
Well, one of the things from my side, and then Mark can certainly speak to it because I wrote a book on this. Literally, when my husband got metastatic brain cancer, he went from lucid at 8 o'clock in the morning, or seemingly lucid, to minute-to-minute hallucinations by midday. Literally, and I lost my husband in that span of time, even though he lived another 5 weeks. But I did not know how to approach him or how to talk with him. Yes, I understood that he had the reason he was acting the way he was acting was because he had brain cancer, of course. But that did not help me know how to work with him and why he had changed from this absolutely loving, wonderful husband that I'd had for 20 years to a person that was sometimes mean. And he was also dying, so there was a lot of emotion with it. So what I'd like to see and what I've advocated for many years and through a book called Connecting Through Compassion, Guidance for Family and Friends of a Brain Cancer Patient, what we're going to discuss tomorrow is ways that the patient's caregiver can be a part of their care, a more effective part of their care by identifying their needs. But Mark, what are your thoughts?
From a caregiver's point of view, in any situation really is to be patient and to not expect. Everybody expects everybody to be like them for some reason, and of course people expect their partners perhaps to be like themselves, and if they do change, if an illness just changed them, it's not their fault that they've changed, and you have to be patient and accept certain things. There was one stage when I was in hospital where I had got very forgetful, and I said to Sarah, what day is it? And she told me. I said, how long have I been here? And so she told me. And a few minutes later I said, what day is it? And so she told me. I said, how long have I been here? And so she told me, and this went on and on and on. And then later on during my stay I heard other people having similar conversations. Now sometimes the caregiver can get uptight and cross about this and think, well, for goodness sake, how many times have I got to say this? But of course the patient can't help it, and who is anybody to judge whether their behavior is right or wrong? And it's actually up to the caregiver to adapt rather than to try and make the patient be something that they're not.
Exactly, and let me give my side of that. What I went through before was people asked me, why is hospice? And I was here, I'd break down, I'd cry, I'd just go through emotions because I was dying. And then 15 minutes later, he would say, well, why is hospice here? And it's exactly what you're talking about, Mark. I couldn't put myself through that again, but I learned from working with an MS in counseling to write Connecting Through Compassion that what I could have said to him was more, they're here to help me take care of you, and that would have been sufficient. So, there's ways of dealing with this, but thank you for sharing that story. That rings true.
Simon, do you have any comments over there in Japan?
Yes, thank you. Thank you very much for sharing your story, Mark. You were saying that you don't have a medical background, but I was impressed by all of by the anatomy, and because you went through it, and this was a
That's
great
probably
learning.
because while writing the book, I researched bits. Yeah. Thank you anyway.
So much for that. It was wonderful for me to hear your experience, and I'm going to enjoy watching this again.
Yeah. Okay. Well, any closing comments, Mark or Joni?
Well, I'll let you go first, Mark.
Right. Well, no, to be honest, my wife and I, speaking for both of us, we're just so lucky to be here. We're so grateful to medical staff, our NHS, as we call it, the British National Health Service. And you do get so many people. I was talking to a nurse just a couple of days ago, because Sarah's just had an operation in the last couple of days, and I was talking to a nurse, and she told me that people really give the NHS and medical staff such bad press on social media, and I can't understand why they do it. I mean, you people, you guys are wonderful. And you know, I take my hat off to all of you. Thank you very much.
Well, it's glad to hear that. And Joni's going to have another show tomorrow at 5 o'clock to discuss similar types of issues. And I thank you guys for coming, and we welcome you to use this platform for any patient-related issues, support issues. Just keep in touch. And thanks, Simon. Thanks,
Thank you very much. Thank you so much.
I enjoyed it.
Great.
Thank you.
Okay. Thank you very much, people.
Thank you.
Bye.
Bye.